Welcome everyone to the Tobacco-Free RNAO webinar, Engaging Indigenous Communities in Tobacco Intervention, Lessons from the Moving On to Being Free program. My name is Jennifer Callahan and I am the Tobacco Intervention Specialist for the Tobacco Intervention Initiative at RNAO, and I will be moderating today's webinar. RNAO is the professional association for nurses in Ontario and promotes excellence in nursing practice and advancing nurses' contribution to the healthcare system. RNAO's signature program, the International Affairs and Best Practice Guidelines Center, develops, disseminates, implements, and evaluates clinical and healthy work environment best practice guidelines. The RNAO Tobacco Intervention Initiative is part of this program. As part of our Tobacco Intervention Initiative, we hold regular webinars, such as this, to build capacity among nurses and other healthcare providers to implement and sustain best practices in regards to intervening with clients who use tobacco. I wanted to highlight also our e-learning opportunities. As you can see on the slide, these are free one-hour courses that are intended for all healthcare professionals. We have a webinar, an e-learn specifically on working to reduce commercial tobacco use in First Nations, Inuit, and Métis communities in Ontario. So if this is of interest to you, you can see the link at the bottom of the slide. We also have recently released our foundational e-learn, which is based on our best practice guideline, integrating tobacco interventions into daily practice. And before the end of the month, we will also be releasing an e-learn focused on youth and young adult populations. Before we begin, I would like to remind everyone to please turn up your speakers. We ask that if you have any questions you would like to ask RNAO or the presenter, or if you're having any logistical problems, please type them in the Q&A box or the chat box during the presentation. The last 10 to 15 minutes of the webinar will be used to address these questions or comments. Also, this webinar will be recorded and archived on the Tobacco-Free RNAO website if you would like to come back to the webinar at a later time. The slides will also be emailed out after the webinar. I will now like to introduce Dr. Patricia Smith. Patricia Smith, PhD, is an associate professor at the Northern Ontario School of Medicine. She has specialized in inpatient tobacco cessation for 20 years, beginning as a postdoctoral fellow at Stanford University School of Medicine. She has led randomized control trials and dissemination studies on cessation and participates in a number of provincial tobacco control committees. She is currently leading 2 ministry-funded projects to implement an evidence-based intensive cessation intervention, moving on to being free, into healthcare settings in Ontario with a focus on mental health, addictions, chronic disease, and northern communities. Welcome, Dr. Smith. We are thrilled to have you here today. I will now turn it over to you to start your presentation.
Great. Thank you very much. Thank you for inviting me here today and your interest in hearing what we're doing up here in northwestern Ontario. I will go through our program. Actually, I'll just start first briefly with sort of like a perspective on smoking cessation programs and what to expect with quit rates, because I have found over the years that sometimes what we tend to think is sort of common knowledge is not so common. So I will look at that first. And if anybody has any questions after as well, do feel free to email me. My email's right there, psmith@nossum.ca. I just want to disclose I have no conflict of interest, and what I will present today is funded by the Ontario Ministry of Health and Long-Term Care, and they do fund me to help anyone across the province at no cost to you to implement an intensive program, this one, moving on to being free. So if anybody's interested, you can contact me as well. So I have found that this is one of the slides that when I do trainings for moving on to being free, people say, oh my goodness, put that up again. We want to see that in terms of what to expect for quit rates at 1 year. If you can get over 50%, that is so amazing. Usually where you find that is with inpatients and a little bit more specifically with patients who have cardiovascular disease and most specifically those who have had a heart attack. If you can get anywhere between 30 and 50% quitting within 1 year and still quit at 1 year, again, that is amazing. If you can get anywhere up to 29% or 30%, that's excellent. And there seems to be this glass ceiling for any kind of behavior change at about 30%. whether it's exercise, diet, heroin, alcohol, smoking, changing your study habits, not yelling at your kids, whatever it may be. If you're trying to make your changes, if you can still be changed, or the people that you're working with are 30% are still changed, you're probably working at the very top of an effective intervention at that point. And you can see the other ones then. I mean, you're doing great. If you can get over 20%, most likely the average, if you drop down a bit, is about 10 to 15%. That's what you get from most programs. For example, NRT by itself, you'll probably get about 10% quit at 1 year. And this is just, I've graphed a meta-analysis, or a number of meta-analyses that really show how clearly you need to increase the intensity of your intervention to increase cessation. So to get anything over 25% quit rate, if you look at the bottom there, those are the quit rates on the left-hand side. And in terms of sessions, you need more than 8 sessions. Total time, you need about an hour and a half to 5 hours, and adding counseling to medication alone. So that just kind of gives a perspective. And then, to summarize it then, so minimum 8 sessions, 1.5 to 5 hours, supplemented or not. You can get those quit rates without medication, but if you're doing medication, it must be supplemented with counseling in order to get those high rates, but not the other way around. You can have the behavioral counseling without the medication and get those high rates, but with medication alone, you usually need the counseling as well. And here's just another perspective in terms of thinking of the population as a pyramid. Public health management, like policy, education, mass media, the cigarette packages, that cuts across everybody who smokes, and that's truly at the population level. And then if you start going up the pyramid and you're thinking about in terms of funding and biggest bang for your buck, often we think of self-help as being the way that we can reach the most number of people, and then based on reaching a large number of people, high volume, that even if your change rates are low, that will make up for it in the numbers in terms of who's exposed. And with self-help, the evidence suggests maybe 4 to 10% of people will quit within a year. Then moderate interventions, or really brief counseling, about 5 to 15% will quit. That would be what you would be offering in your clinical practice if you could just do a brief intervention, anywhere from a 2A, 3A, 4A, 5A, where you're then referring people out for follow-up somewhere else. And you could probably expect a 5 to 15% quit rate there. That might change a little bit if you're adding NRT to it or other types of pharmacotherapy. And then if you do maximal intervention, which is really intensive counseling, you can get 25%, and we have achieved up to 70% quit rates at 1 year with post-MI patients. And if you think back, in terms of Ontario, where could you get maximal interventions, intensive interventions? Prior to 2005, when they started funding family health teams in the province, there really wasn't a lot of opportunity to offer intensive counseling, unless it was through a special program like a stroke or a cardiac rehab program. But certainly our options have expanded in family health teams, in community health centers, in public health. So now we have more opportunity to provide intensive counseling. I keep going to my arrows on my computer as opposed to using my clicker here. The idea here, when I'm looking at program reach, you can tend to reach more people with a minimal intervention, because with print materials, for example, you can just distribute them widely, and you tend to have lower reach with intensive counseling programs, and that's simply because they're more costly and it's more difficult to do, and you need the resources in terms of staffing. And the opposite is true, though, in terms of what you get for outcomes. You get much better outcomes at the top of the pyramid than you do at the bottom. And sometimes it's what you find in terms of how reach and efficacy play out up here in northwestern Ontario, because we're so small in terms of our population. In fact, we get a bigger bang for the buck when we go for intensive counseling, simply because we have smaller numbers and we get 3 times the quit rate that you do when you get when you're using a minimal or a self-help intervention. And what you can do with your own interventions, if you're doing brief counseling, for example, anywhere from a 2A to a 5A within your own practice, and you don't have the opportunity to do a lot of intensive counseling with your clients or your patients, when we're talking about intensive interventions, that means just stacking as much as you possibly can into the intervention, as many components. So if you can add pharmacotherapy, add it. If you can do even quick follow-up sessions, say you're a foot care nurse, every time you're talking with your clients, just ask them how it's going. That adds to the amount of time. If you can add any kind of print materials or webinars, so going down into the minimal, do that. If there's anywhere you can refer them for more intensive counseling, to the Smokers Helpline, or maybe you have something internal in your clinic or your hospital or in your public health unit in your community. So whatever you can do in terms of just getting more and more components, that will increase the quit rate. And of course, support your clients and your patients. So the program I work with, Moving On to Being Free, is an intensive program. It started out as an inpatient program at Stanford University. It did start out as a nurse case managed approach, and now we've expanded to other providers, social workers, dietitians, kinesiologists, community health care workers, public health, health promotion workers. So we now just deliver it through whoever wants to deliver it, but it did start as a nurse case managed. It is 8 or more sessions depending on what your client or patient wants. We follow up for at least a year longer if they would like it, and it's just the basic protocol is about 2.5 to 5 hours a year. Again, if they want more sessions, they can add more sessions, and I'll show you how it works. But first, the evidence base. Moving On to Being Free is really a derivative of Staying Free. When it was a program just for inpatients, it was called Staying Free. It was developed in 1982 at Stanford University, and there's an interesting story behind how it developed. Stanford, at that point in the cardiac rehab program, they were looking at nurse case managed interventions for cardiac rehab, and back in the early 80s, cardiac rehab was basically exercise, so they were doing home-based exercise. And what the nurses were finding when they followed up with their patients after hospital discharge to see how they were doing with the home-based exercise program was people were telling them about smoking. And they were telling them that they quit in the hospital. They got so scared, basically, after their heart attack that they quit. And the nurses started finding this pattern. So they finally did a randomized trial on it. And what they found are the people who did quit smoking during hospitalization or the first 3 weeks after hospitalization were significantly more likely to be not smoking at the end of 1 year. And in fact, if you look at this graph, it's the second study in Taylor in 1990, and they had a 26% increase over when they did run it as a randomized trial in terms of whether they received a program in hospital after they had a heart attack or not. So they really were able to jump up that quit rate. There's been 7 randomized trials, clinical trials. I ran 2 of them here in Canada, one with post-MI and bypass patients in Calgary at Foothills Hospital, and one for general hospital patients in Kitchener-Waterloo in 3 hospitals. We've done 3 translation studies, and the key thing here that's really unique about this program is that we get consistently high results, and we're the only program, I'm bragging here, but in the world who have achieved congressional top-tier evidence, and that simply means that we consistently get these high quit rates, and we're consistently getting a significantly higher quit rate than our control groups, and we have run enough studies that they can actually do a meta-analysis on our studies alone. What I've done with the graph here is you can see these are randomized trials. I've simply graphed Nancy Rigotti's meta-analysis for inpatients, and what you see is on the left-hand side, those are cardiac studies, and if you're cardiac, or you get much higher quit rates with cardiac patients than you do with anybody else, and the highest among those who have had a heart attack because they're pretty darn scared. And then on the right-hand side, you see these are studies, inpatient randomized trials with general hospital patients. The stars, anything that has a star, are those were our studies. And you can see we get the highest across all the studies that are out there. And we also get a nice big gap between the intervention and the control. This is how the program works. And we made it 5 steps only because when we took it from the inpatient program and also made it available in the outpatient, the nurses we were working with said, oh, there's so much to remember. I don't remember how many, because they were doing it on top of their regular clinical duties. I don't remember everything I'm supposed to remember in terms of what happens when and how to explain it to my patients and my clients. So we just tried to break it down into 5 steps. Basically, in step 1 is enrollment, signing up and signing informed consent, because we do run it as a study, a translational research study, and completing the smoking history, which usually happens at the same time as the initial session. The initial session is in person. That's where you review their smoking history and you make some decisions. And the reason we write it that way is to take the pressure off, because you've probably found that sometimes if your clients have made an appointment to come to see you about smoking cessation, some people think they need to be quit by the time they see you. So we're just trying to take the pressure off, going, no, it's just the time to make some decisions. Do you want to maybe use some medications to help you quit? Do you want to set a quit date? Do you just want to start tracking in the beginning? Do you want to start cutting down? Let's just develop an initial plan and some initial strategies. And it's all based on what the client wants to do. So this first session takes about an hour. And then they have an optional, if they do want to set a quit day, which most people don't. The literature used to say you must set a quit date in order to be successful, but the newer literature is now saying no, most people just want to cut down first, a harm reduction approach. And we're finding that if you try to force people to set a quit date, they get paralyzed. The step is simply too big. And that's something good to remember in behavioral interventions or changing any kind of behavior. We don't make changes or we plateau out when the step is too big. And so there's no point in pushing people to do something they're not ready to do. And so that's optional. And then really, step 4, this is our 8-week program. We're looking at this in terms of if you went to a physiotherapist and they put you on a program, they'll say, all right, let's start with, say, a 2-month program, and we'll reevaluate at the end of that and see how you're doing and make decisions then. So we frame it that way. And the program is actually phone counseling as opposed to in-person. People can certainly come into the clinic to see you if that is what works with your clinic and with your client or your patient. But it did start out as phone counseling because they wanted to make it, when it was developed, they wanted to make it very convenient for the patients so they didn't have to come back to the hospital. Remember, this was developed in the San Francisco Bay Area on the peninsula, and, you know, distances can be quite far and expensive in terms of getting child care or transportation, parking, those kinds of things. So they wanted to make it really convenient, and we're finding that it is very convenient to do it by phone. And the protocol is basically every week for the first month, and then every second week for the second month. For inpatients, we also have a 2-day post-discharge call, and it's sort of to catch people before they get back to their regular routines, but give them enough time to get comfortable back at home, adjusting back home, because most people when they're hospitalized either quit smoking because of the smoking bans or they substantially cut back, and so you want to help them and support them before they go back to full-blown smoking. And then the 5th step, and these aren't necessarily linear because Step 5 doesn't have to follow Step 4. It's simply a check-in at 3, 6, and 12 months because those are the standardized outcomes. And the ministry looks at the 6-month outcome, and if I publish, they're wanting the 12-month outcome. So those are standardized. You can keep on adding more Step 4s, as many as people want, as long as it fits your clinical capacity. And some people do go more than a year. Some people, they relapse, they cycle around, and the providers just keep supporting them as long as they need support. So the initial session is about 1 hour. If you do have a quit day call, and they can have as many quit day calls as they want, because if they make a quit day call and then they don't quit, then they can set another one, and this can happen a number of times during the year. And it's just a really quick call to say, hey, how you doing? 1 to 5 minutes. The Step 4 counseling calls are about 10 minutes on average. I've been told by some of the providers that sometimes they're as quick as 5 minutes if people are doing super well, and sometimes they're longer. They're 20 minutes, around 20 minutes if they're still in the early stages and they're really struggling and they're trying to figure out new strategies. And then Step 5 is usually 1 to 5 minutes, but we're modifying this a wee bit because what we're finding is sometimes our Step 5 calls really overlap or coincide with additional Step 4 calls, and so we're making them into counseling calls. But normally, if you're just following up, it's 1 to 5 minutes, and Step 5 also provides an opportunity to re-engage. Because what happens, as you well know, is that when people try, they often try to quit smoking, and then they trip up and they keep trying. It's 2 steps forward, 1 step back, and then they'll hide from you. They'll hide from the calls. And so sometimes when you finally do get a hold of them, you can just re-engage them, and no judgment, and they just pick up from where they left off. The counseling process is the same. After the initial session for step 3, 4, and 5, it's always the same. It's case management. Everything is scripted, standardized. That ensures treatment equity and ability to evaluate, because you know what you've actually delivered. It's not up to every individual clinician in terms of how tired they are that day or how much time they have. But here's the thing, is it's actually individually tailored based on how the client responds. So it's patient-focused. We always open the session by asking about tobacco use and basically, how's it going? Have you been smoking? How much are you smoking? Are you cutting back? And then we do the clinical management, review any kind of medication that they're using to quit smoking, how they're using it, what dose, are they having any issues, any side effects. We have a one-item screen for withdrawal, and if they say yes, they're having some, or they don't know, we have a withdrawal checklist. We have a one-item screen for mood, because nicotine can mask depression, and so you want to be right on that. And because this is delivered in clinics or hospitals, there's usually some place that you can refer the patient or the client to get help in these areas. We also have a one-item screen for weight, because about half of women are really worried about gaining weight when they quit smoking, and it's about reassuring them, don't worry about the weight right now. It's safer to gain the weight than to continue smoking. You know, do you want some help with any of your weight management? And also check in with any other kind of concerns. Then it gets into the counseling piece and coaching piece, the support piece, what's working, what's not, developing new strategies. And in the next slide, I'll show you how we develop the strategies, and then close the session in terms of what are your goals for the next session, and then just really confirming when the next appointment is. So it's always the same. People get used to what to expect. It's not a great big black hole. What will counseling be about? They get really used to the pattern of what you do with them. It is a theory-based intervention, and it's grounded in Marlett and Gordon's relapse prevention model. That was developed back in the mid-'80s, and it came out of the addictions research and area and treatment. Basically, and many of you have seen this, even if you didn't know this is what it was called, and you probably do this in your clinical practice, is basically every behavior has a context. Every cigarette is a behavior, so every cigarette has a context. And if you smoke a pack a day, say 20 or 25 cigarettes a day, that means 20 or 25 times a day, you're going to be triggered to have that cigarette because it's context specific, situation specific. That situation can actually be an external situation like the setting. It can be a thought, emotion, it could be a person, it could be time of day, it could be a craving, but there is something that's going to trigger it. And the key to changing any kind of behavior, and what we look at here applies to all behavior change, not just smoking, is that you need to plan and act in advance of hitting that trigger situation. So you have a cup of coffee, you have a cigarette. You have a meal, you have a cigarette. You get in the car, you have a cigarette. So if you pick even just one of those situations and you figure out what are you going to do instead of smoking, you plan it before you ever get there. That's your coping strategy if you go on the top line. Then if you have thought about it ahead of time, you're more likely to engage that strategy. You engage it, you're more likely to be successful. If you're successful, your self-efficacy, which is your situation-specific self-confidence, that goes up. And self-efficacy is the only predictor across all behaviors of who actually makes successful change and who doesn't, only being the only consistent predictor across every behavior, and smoking in as well. Now, if you didn't plan in advance, think about if you drop down to the bottom path there, you have no coping strategy, so you're always going to do what you've always done, basically. You're just going to hit the situation. You're not even going to think of it, because most of what we do is an overlearned behavior, a habit, and you're just going to do what you've always done. And so that means you're going to smoke, and then if you've already quit, that means it's a relapse or a slip, and then your confidence starts to go down, and that can sometimes stop the process right there in the tracks. But with an intensive intervention, when you have that constant support from your provider, those little slips and relapses don't have to be forever. It's like if you have a piece of cake when you're on a diet, that's not the end of the diet. And if you have someone there coaching you, reminding you it's not the end of the diet, that can really go a long way to being successful. So two other theories, Bandura's social cognitive theory, within that, the self-efficacy we just looked at, and self-regulation. Self-regulation is really boils down to identifying your goals, developing strategies, continuing to monitor, and adjusting as you go. So basically, just looking at what we just did on the bottom. And then finally, also, if you remember operant conditioning from your Psych 101 classes, the rat boxes, the light comes on, you press a bar, and you get your reward. That's the ABCs, the antecedent, the light comes on, the behavior, you press the bar, and the consequence, you get the food pellet. And so when you're developing strategies, we like to go broad like that because that is what the evidence supports in terms of, all right, how could we change what's triggering it, triggering the behavior? So, for example, some people, when they first wake up in the morning, they want to have a cigarette, but what they have found is that if they brush their teeth, they no longer want to have the cigarette right then and there. And so that would be changing really the trigger because it doesn't taste the same, and so you don't want to do it. The behavior piece might be having a piece of gum, whether it's regular gum or nicotine gum, instead of having the actual cigarette. A possibility for changing a consequence is often you have a cigarette and you tell yourself, whoa, that just feels so good. And if you're aware of that because you're tracking it, which is what we encourage the clients to do, then you can actually change it. Just change it to like a cool or a neutral thought, as in either, oh, no, I didn't want to have that and put it out, or something like that. So we work, and we never come up with the strategies. We wait out the clients and the patients to come up with their own, because if you suggest something, then they'll tell you all the reasons why it won't work. So, you know, have you ever tried before? What did you do last time you tried? What worked for you? And if you get them thinking about it and sort of digging out in their repertoire what they have, then they're going to be much more successful. So that's the theory part behind it. And then we also, our whole program, you can do it on paper, or it's also supported by a computer platform. It's a web-based program. It has scheduling features because some people, if they're a full-time smoking cessation person in your clinic or hospital, you could potentially have hundreds of clients. So how do you track all of those follow-up sessions? So this cues you every day you go in, and it tells you who you need to call. It also allows us then to do program evaluation in real time across, you know, our large geography up here and lots of clinics. This is how it works in terms of recruitment then. So that's the program. So how do you actually run the program? When it's done on an inpatient basis in the hospital, it's a centralized approach. And what we have up here, all 12 hospitals in Northwest Lynn, they all use a centralized admitting system so that you're not admitted on the floor, you're actually admitted in a centralized area in the hospital before you go to the floor. And we have this one question, have you smoked or used tobacco in the last 30 days? And that gets recorded in their admitting records, and then the cessation nurse reviews the daily census, and we have a special one that actually has a column of who smokes and who doesn't. And then that nurse will go into the charts to look to see if it's appropriate to approach the patient, if they're stable, basically, is what we're looking for. And if yes, then he or she will approach the patient at the bedside, explain the program, explain the research piece of it, and start right then and there. So the initial 1 hour initial appointment's done right at the bedside, and then all the follow-up is done post-discharge. So everything is based on the discharge date. If it's done in an outpatient setting, it's more of a decentralized. So the centralized being, it's usually one person, the question is asked in one place, and then it shows up in one place, and then you can approach the patients. But in the outpatient or clinic setting, it really is usually decentralized, depending on your clinic. And so what we have found is that the providers who are trained to develop this, or to deliver this program, I should say, and we have nurse practitioners, nurses, social workers, dietitians, diabetes educators, kinesiologists, community health workers, all deliver this program up here. And either they offer it when they're seeing their clinics or their clients for other reasons, or other clinicians in the clinic just refer to these people who've been identified to deliver it. Some of the communities have also do it through referrals from the community providers if they don't have One of our communities, they don't have a family health team, so the primary care doctors refer to the hospital. And we do outreach in our northern communities, the First Nations health directors, the nursing stations, in Cancer Care Ontario, the Aboriginal Tobacco Wise lead, and I'll look at that a little bit more in a minute. They all do referrals to the program. So up here in Northwestern Ontario, we're 50% of the land mass of the province, but we're really small in terms of how many people that we have. Only 224,000, and half of them reside here in Thunder Bay. Our smoking is really high, 33% in rural, 25% in Thunder Bay. And if you look past the line of Red Lake, Sioux Lookout, there are no, there's no pharmacies, there's limited phone access, often limited internet access, so they don't have the same access to smoking cessation supports that we do in the rest of the province. So then by centralizing moving on to being free in our clinics and our hospitals, we've been able to reach a greater proportion of people who use tobacco who wouldn't otherwise seek help on their own or have access to smoking cessation programs. So even though we're only in a few of our communities, about 20 programs, but in a handful of communities, we've reached people in 73 communities, including 36 First Nation communities, 36 rural, and 1 urban. So Menoyawin is the one I'm going to talk to you today about. It's a hospital that serves Sioux Lookout and 33 northern communities. There's no hospitals or clinics north of Sioux Lookout, just nursing stations. And as I said, they have high smoking rates up there, just like we do in Thunder Bay and the rest of Northwestern Ontario, limited access to other options for smoking cessation, so nothing north of that big star. 89% of everybody that enrolls in moving on in Sioux Lookout at Menoyawin are Indigenous, and 71% are from the fly-in communities. They don't have any roads. This is just a blow-up of Northwestern Ontario. You can see Sioux Lookout's the big red dot. Anything with yellow or red are the communities served by Menoyawin, and we have people enrolled from all of those communities. 28 of the 33 northern communities don't have roads. They're fly-in communities. So having it at Menoyawin is really a needed service. And that's just a little bit about Menoyawin. They do have a special mandate in Ontario hospitals to provide services that address the health and cultural needs of a largely Indigenous population. And they have acute care, long-term care, ambulatory care, mental health and addictions, community-based and traditional healing services, and we offer Menoyawin Menoyawin offers moving on through all of those settings. And then they also have ceremonial rooms and interpreted services. That's just Menoyawin. It's really a park-like setting. It's really lovely. When you first walk in, this is the hospital. They have a dream catcher on the top. There's this they have healing circles and tiles on the floor. They have this, there's a fire pit when you first walk in. And as you walk down the hallways, that's an inverted canoe, the ribbing of a canoe in the hall and the ceilings. And right next door is the hostel where people stay when they fly in. There's a big ceremonial drum on the top of it. When you first walk in, underneath that drum, you walk through a teepee. And then the hallways, there's ceremonial feathers in the hallway, so it's a really nice place to give care. And here's Lisa Seamark, the nurse at Menoyawin, who delivers the program, and she really is quite magical. So what she has to say about the program is that many of their clients and people living in the northern communities are really sick. They want to quit smoking so they can start to heal. But until they had this program, there weren't very many options for cessation help, especially in the remote areas. And she says that this program is a perfect example of patient-centered care because it meets people where they are at in their lives and provides the support and skills they need to manage their health and become a model for other people in their communities, and that we bring the program to them so they don't have to seek it out, because we know that if you leave it to people to seek out any kind of program, but smoking cessation especially, less than 1% of people will ever seek out help. One of the things she does with the program, so it's a standardized program, but she does deliver it to the context, delivers delivery to the context. So, for example, they have a prescription medication 2-week withdrawal program where they fly people in from the northern communities to withdraw off prescription medications. And what she has done is she's integrated moving on to being free as an education and an activity group once a week with with this withdrawal program. More than 50% of people who are in the program smoke, and almost all of those people who smoke then join up for moving on to being free through that program. She also delivers a lot of moving on to being free through interpreters, and she always just simply forgets to tell me that this is a part of the program, and because that's just how they do business up there at Minoyawan. She also integrates this with other services that people want or need. So it's a very in-depth program, so as you're going through the history, you find out what other people need. If they need housing, help with housing, she gets them referred to social workers. If they need help with their diabetes management, she gets them referred to the diabetes management. It's also an example of integrating it into other treatments. In the cardiopulmonary lab, if they do stress testing and pulmonary function tests, that gives people a concrete visual test that their breathing is compromised, for example. But to be clear, we never use that as a scare tactic at all. It just so happens that is what's already happening, and so then it's offered as a service. And a lot of people do actually sign up right then and there and leave with a quit plan and some NRT. She's also tailored the intervention to what people want, making it interesting, relevant, hands-on. So she went to Value Village and bought up all the needles and yarn and started teaching people how to knit. Because remember, we're looking at what are you going to do instead of smoking in every one of these situations. And you can't read the note, but there's a little note in front of that basket, and came from one of the far, far north communities, and the note said, it was to Lisa, and it said, I've been busy knitting, not smoking, and she sent her a scarf. And now other providers in the hospital, whether or not they deliver the smoking cessation program, they call themselves knitters on call. So on their breaks, whether it's lunch or coffee breaks, dinner breaks, if people want help with knitting, patients want help, they go to the bedside and help people with their knitting. We also have these quit kits that assist people with doing something instead of smoking. We have adult coloring, word find puzzles, Sudoku, playing cards. It's especially helpful for people who are bored. They're sitting or they're lying there in their rooms as inpatients. So we do things like that. We've also partnered to enhance services. We haven't in the past had access to no-cost NRT, but starting this year, the ministry asked us to partner with CAMH, so we'll be able to offer free NRT through that. But Lisa did partner with the Northwest Public Health Unit to get free NRT. And then also with Cancer Care Ontario, the Aboriginal Tobacco Wise lead. Nicole is amazing, and she advertises the program as she goes up to these communities, and often she sets up the education systems and video conferences Lisa in. They do an education session, then people can talk to Lisa on their own, sign up, and then she follows. She might not ever even meet these people in person, and just follows up through video conference. Lisa has some great takeaways. One is respect, to treat others the way you would like to be treated, because everybody always says, well, how do you get such great uptake? She gets amazing uptake in the program. And by the way, one thing I didn't mention, moving on to being free, overall, we get the highest quit rates that have ever been published for general hospital patients. We get about 35 to 36% of people are still quit at 1 year. Lisa, and that's about, the mix in there is about 30% are cardiac, about 10% have had a heart attack. Lisa is getting 54% quit rate at 1 year, intention to treat, meaning if they drop out, she doesn't get a hold of them, they're counted as smokers. There's no one that has had a heart attack because everybody, it's a community hospital, so everybody gets shipped out somewhere else. So these are amazing quit rates that she's getting in success. She always asks permission to talk about smoking and explains that you'll be asking before you ever ask, and you're giving a reason why you're asking. So you don't just say, do you smoke? So she clarifies that everybody's being asked. I know that you have that in some of your other guidelines, and the reason that they're asking is because smoking can affect the medical condition, and there's also some immediate positives that they might have if they quit, such as some of their medications might work better, faster healing, shorter hospital stays, so they can go home sooner. And then she says, so I'm going to ask you now, do you smoke? And it's amazing how many people will tell her that didn't previously tell anybody else. Empathy. It's really important to understand, as you well know, I'm preaching to the choir here in terms of the context of people's lives. And it's important that we care for one another, especially when you're in these tiny places where everybody knows everyone. what she has found, this is very interesting. We used to avoid trying to enroll people over the meal times, but what Lisa ended up, quite by accident, finding out was that she sits with people over the mealtime, and people really like it. They welcome the company because over 80% of people there at the hospital, they're really far, far away from home, a plane ride from family, friends, communities, and so they're more apt to have a conversation over meals than during the busyness of the day when people are coming and going and they're getting pulled out for their testing and et cetera. And they're more likely to become a participant in the program, so that's kind of interesting. Caring and advocacy. Lisa really sees this as a way to provide holistic care. Because we take this comprehensive history for the program, it provides an opportunity to see what else is going on, as I mentioned before. So she suggests being really aware of what services you offer in your organization. And sometimes this can really get, as you do the history, it can get the ball rolling. You start referring people to the things they need. If they need a dietitian, if they need housing, you go to the social worker. And then people have started to trust her because then it doesn't look like she has this single agenda to stop people from smoking and putting her agenda ahead of theirs. You show that you care by looking at the big picture. And also by looking at the big picture, you start this sort of healthy cascade that helps people heal. She also loves this one part. We have the drug interaction sheet that goes with the program. A lot of medications interact with smoking. It's not with the nicotine, it's smoking itself. And as she goes through it, she finds out people don't know what medications they're on. So she tells them they have a right to ask and find out what it's all about. Why are they on these medications? And people didn't think they had the right to do that with their physicians. And they come back and they're very happy. And they're saying, this is what I'm on, or slap down the piece of paper and going, this is what I'm on. And people start to feel empowered and have a little bit more sense of control over their own care. She also says it takes time to explain why they might need the program and not to go it alone. There was a good example from Veronica Proper when she was running it at Thunder Bay Regional Hospital, walked into a room and a patient just slaps his arm and goes, no, I'm good, I got the patch. And so the whole idea is to be able to then, how do you work around that and really explain that it's really beyond the pharmacotherapy alone, and it's planning for triggers and as well monitoring the pharmacotherapy because it is a medication and it can have side effects. Just explaining that you must be prepared for what's going to trip you up. What are you going to do instead of? So it's not just enough to prescribe or recommend or give out the pharmacotherapy or NRT or the prescriptions, that really there are side effects, and as Lisa knows, it's really negligent not to be following up with people. And she had a very good example the other day of a fellow who was using the patch, and the pharmacist didn't say anything to him, and when Lisa followed up with one of the calls, he was having terrible reactions to it. She asked him to come in. She said, oh my goodness, yes, you're reacting to the glue on this, got him switched over to the inhaler and showed him how to use it. And he said to her, how do other people do this? I mean, if nobody's there to explain it to them, how do they know? So that's, it takes time to explain it, but it's worth it. And then the ongoing monitoring, planning for triggers, adjusting as you go. And Lisa says it's always important to end every session with, is there anything you can think of before the next time we talk that might trip you up or that you're worried about? And the other thing that we have found, or Lisa more than some of our other communities, is that she has found to offer extra calls and support when needed, like over the Christmas holidays. We thought in some of our discussions, we have clinical rounds every second week just, for community practice. And one of the things that came up to our first Christmas when we were running the program was, well, what do you think? Should we leave people alone during that time? People want some privacy with their families. And what Lisa started finding was that, as we know, a lot of people have a very difficult time, especially over the Christmas holidays, depression, lots of family issues, and she found that a lot of people actually wanted more calls over the Christmas holidays, so she opened up her own personal time to start calling them in terms of, cut her vacation short and went back to work for some of these and made sure that she connected with the people who needed help. So In terms of summary of practical takeaways, because she has been so incredibly successful with this program in the northern communities, and it's because it's run as that centralized place. Each one of these communities, it'd be very challenging to run their own program because they have high turnover. They have, communities are small, often 300 to 500 people in the communities. The nurses in the nursing stations are way too busy. And often there's high turnover there as well. So having this central place that people know that they can refer their clients, she can do it through video conference to them if they can't make it into Sioux Lookout or they're not coming down to Sioux Lookout for their care. When they are in Sioux Lookout for their inpatient, that's when she offers it right at the bedside and does follow-up with them. And then if they don't have telephones, she either sets it up through the nursing station, that she'll call the nursing station. Someone in the nursing station goes to the person's house and tells them, all right, Lisa's on the phone for you. Come back as soon as you can. And then the person comes when they can. And then the nursing station calls Lisa, and then they have their conversation. Lisa also sets it up so that when people have to come back for their follow-up calls or follow-up appointments in Sioux Lookout, she makes sure she sets up outpatient appointments with them if they don't have any phone follow-up or phones that she can follow them up with. So she just really works with the system that they have, but the centralized piece of having one place that everybody can go has really made a difference. And then there's also one of the kinesiologists with the diabetes program. There's 5 of the 33 northern communities that you can actually drive to. They have roads, and so she takes the program on the road, and she goes into the communities and offers it as they're doing the diabetes, as the diabetes team goes in and offers the diabetes management. So respect, empathy, caring, advocacy, and holistic care, taking time to explain it. Oh, and one point I didn't specify was making it culturally safe, trauma-informed, interesting, relevant, hands-on. So trauma-informed is always simply assuming trauma's in the room. So if people don't carry through with what they say they're going to do and things are too hard, you understand it's meeting people where they're at. Ongoing monitoring, planning, and support, and ending all sessions with the thought-provoking question, is there anything you can think of before the next time we talk that might trip you up or that you're worried about? So you're really helping people learn skills in terms of, that's how I start making changes in my life. I identify these situations and come up with strategies. So there we go.
Great. Thank you so much, Dr. Smith. That was an excellent presentation. And for everybody else, we have some time for questions. We've had some questions come through already. You can type those into the chat box or the Q&A box. So we'll start with our first questions here, Pat. And the first one is, what is it about counseling that makes smoking cessation more effective than medication alone?
I think it goes back, if you think back to then, so you put the patch on and it takes the edge off. But then 25 times that day, you're going to be triggered to do, you're still going to be triggered because it's not just all a physiological craving that leads you to want to smoke. So even think yourself, or in your own home, think about where you put your toothbrush in your bathroom. Let's just say you put it on the right-hand side. Let's just say then you move that toothbrush, do it tonight, move it, put it on the left-hand side of your vanity. And look at what you do in the morning. You will automatically reach on the right-hand side. We're cognitive misers, and what we do is, it's probably quite it's survival, I'm thinking, in a lot of ways. So we don't think about things that we don't have to think about. And almost every behavior that we do that's repetitive then becomes what we call a conditioned response or habit. I know that some people don't like the word habit, but in clinical psychology it simply means an overlearned behavior, that the neural pathways laid down. You just automatically do it without thinking. If you used to smoke in your car, you'll automatically get in the car and you'll light up. And so the patch isn't going to help that. So you actually have to be very conscious of what you're going to do. And any behavior you want to change, what you have to do is you have to put your attention on the behavior because now it's automatic. Think about when you learned a new behavior like driving. When you're coming up to a stop sign, your instructor would be saying, all right, we're coming up to a stop sign. Start taking your foot off the gas and slowly put it on the brake. And that's someone else. They're giving you the instructions. The next step is that we then sub-vocalize, whether it's we say it out loud or even in our own head. We go, all right, coming up to the stop sign, take your foot off the gas, start putting it on the brake. And then eventually it becomes automatic. Your environment triggers you. I'm sure you don't think about that when you come up to a stop sign because you're triggered by outside cues. So that's what the smoking does, and that's why behavior helps. Because when you're working with the counseling, you're always looking at, all right, what's coming up next? What can you do instead of? And you plan it before you get there. Otherwise, it's just like coming up to the stop sign. It's just like grabbing your toothbrush. You'll always do what you've always done without any thought.
That's great. Thank you so much for that response. We have another question that says, what is the difference between brief counseling and intensive counseling?
So brief counseling would be your 1 to 5 minutes, going through your a 2A, 3A, 4A, 5A type of protocol, so asking about tobacco, advising them to quit, maybe assessing if they're ready, giving some assistance, like, I've got these resources here, I'm going to give them to you right now, and would you like me to refer you to the Smokers Helpline? So that might be a brief intervention. And then the intensive, as you've seen, that's what we've just done. As you go through it. A brief intervention could also be a little bit more. Some of you might run the Ottawa model, for example, and there's some, you do a little bit of counseling on that consult form, and sometimes it might be 10 minutes, but it's not, you're not taking a full hour and then following up, it's not case management, and then following up every single time with the same things. All right, last time, you said you're going to do this. How's it going, right? Oh, okay, well, maybe the step was too big. Let's take a step back. Or people say, no, completely went back. All right, well, all right, let's see. What was working? How many did you cut back to? What would you like to try this time? Let's not go too big. And so there's that whole support and encouragement piece as you're going through it as well, where it's the case management. You're pulling the threads through as you go. Every single session, as opposed to the brief, is just saying, all right, would you like some nicotine replacement therapy, or would you like a prescription for Zyban or Champex? And here, I'll point you in the direction of some resources, and I can send you over to the Smokers Helpline, and they can do some follow-up. So if they do get referred to the Smokers Helpline, then the Smokers Helpline does go through lots of what we just talked about here. And in fact, I ran the pilot for the Smokers Helpline before it was ever rolled out across the province, and Moving On is actually the program that initially was underneath the Smokers Helpline. Does that answer the question between brief and intensive?
Yes, I think it absolutely does. If anyone has any further questions about brief and intensive, they can type them in the chat box. So for our next questions, we've had quite a few questions about e-cigarettes. So generally, does smoking cessation include quitting e-cigarettes? And I'll read another question here, which is, how prevalent is the use of e-cig/vapor products in your communities? And how do you see the adaptability of your program to cessation for e-cig and vapor products?
Okay, let me start with the easy question first. The adaptability is absolutely this works. So if you go back to that model, the relapse prevention model, that was developed for it was developed in the addiction, so it applies to anything. You could use that same model for exercise, diet, alcohol, any heroin, any street drugs. You can use that for smoking. You can use it for marijuana. You can use it for e-cigarettes. It goes back to the basic premise that every behavior has a context, and that's what you're working with is the context. So I don't know what the prevalence of e-cigarettes is up here in all of our communities. And then in terms of the evidence base right now, there is a raging debate in the literature right now. The UK is very pro e-cigarettes, and they're saying switch to e-cigarettes because it's way less harmful than smoking, and it really does help people quit. However, in North America, both Canada and the United States, they're a little more cautious because some of the data, and it's, correct me, anybody feel free to correct me here, I might not be quite up on it, but my last read is that it's still mixed results, and what they're finding, and a few things that they're finding, is that a lot of people, they'll try vaping, and they'll start vaping while they smoke, but then they also continue with their cigarettes, so they end up doing both. And there's not necessarily strong evidence that they will quit. And then there's some new evidence that shows that more people are trying vaping who don't smoke because they're curious about it, and then they start vaping, which is not a good thing. And more there's evidence coming out about the harmful effects of e-cigarettes. So just like anything, I mean, basically you shouldn't put anything into your lungs except air. So if you're sucking in the vape, you are sucking in chemicals, and some are much more carcinogenic than others, like certain flavors, like I think it's the berry flavors, like strawberries and things. And then there's some new evidence out that suggests that e-cigarettes might be just as harmful as regular cigarettes in terms of risks for heart attack and stroke. And so the thing to remember with e-cigarettes is, in general, they might be less harmful than regular cigarettes, but they're not harmless. And we don't know enough. More and more evidence is coming out about different chemicals in them that are harmful, that lead, for example, to popcorn lung. I mean, there's all kinds of things that are coming out. So it's a strange balance. We're at a strange crossroads right now trying to figure it out. And so when you see the controversies, a lot of it is coming from the UK just really pushing it, saying, no, this is the way to go. North America going, I'm not sure about that. And also you need to be careful because big tobacco is just gotten behind e-cigarettes, and they're using all the same tactics they used with promoting cigarettes 50 years ago. They're now using that with e-cigarettes. And so some of the stuff that I have read says just be careful because now we're being manipulated one more time from the same area, like big tobacco, but now it's about e-cigarettes because they own the companies that sell them. So I didn't really answer, but I answered the best I could. It's not black and white, but this program would work if you wanted to help people get off e-cigarettes.
That's great. Thank you so much. And kind of in the similar vein to that, we have a question about cannabis. So cannabis prevalence in these communities, and whether the program can also address dual users who are using cigarettes and cannabis.
Absolutely. Again, I don't know our cannabis use. Everything is very high up here. All drug use is higher up here, my understanding, than the rest of the province. Dual users, we have a lot of those, and people that have learned how to do the exact right mix of tobacco and cannabis, poppers, I believe they call them, and so just enough so they get that the marijuana chills them out, and the nicotine, being a central nervous system stimulant, perks them up just enough, and they figure out what that perfect match is. Sometimes they're taking the tobacco out of their cigarettes and they're putting them in pipes even and getting the mix to go. So absolutely, it goes back to that model, the relapse prevention, identifying every behavior has a context and figuring out what you're going to do in the context.
Great, thank you. We have a few more questions. I'm not sure whether we'll be able to get through them all. If we don't get through any of these, we can include the responses in an email that will be going out. But for our next one, let's say when a patient is not willing to start smoking cessation, is it recommended to continue monitoring and it is recommended to continue monitoring and provide motivational counseling. What are some things you could say and or do to motivate a patient to consider smoking cessation?
Yeah, that's a really tough one. I think a lot of it happens in the delivery of it itself, in terms of, if you go back to what Lisa had suggested about the respect piece. So this is why we're asking. And so it really depends on your context. So this is why we're asking, because it can affect some of the medications you currently use, and even shorten your healing. And it's always their choice. So if you thought about it, I know when Veronica was running the program at Thunder Bay Regional, sometimes she would have people that would be hospitalized multiple times, and every time she came in the room, it was like they recognized her. But because she always made it about them and their choice, people didn't chase her out. And she used to like to say, well, I just want people to know I'm not scary. I'm not holding a big stick here. And so she just would open up the conversation and saying, have you thought about it anymore? Are you interested now? And well, let me know. And here's a good line. Offer is always on the table, and simply letting them know what is on the table. So offer is on the table. I'm always here. to help you if you want. Here, take my card. You can even call me when you're after your discharge if you change your mind. Or say you're in a clinic that offers the free nicotine replacement therapy. Well, we've got it, just so you know. And if you ever want to know about it, you can just come back in and we can talk about it. So you always say, you don't make it definitive right here now, I think is really the end thing. It's just saying, you can come back. The offer's on the table whenever you'd like. And sometimes people will say, some of the people that were hospitalized multiple times, Veronica would walk in the room and she often had people say, all right, this has got to stop, it's time. But that's because she created the rapport around it and didn't make it you're a bad person and shake a finger that you shouldn't smoke, you should know better. It's like, yeah, I know it's hard. So when you're ready, I'm here.
Great. Thank you so much. We have a few other questions. What we'll do is we'll include those in the email that will be sent out. Our time is now up, and thank you so much to everyone for participating in this webinar. All the participants will receive an email from the RNAO within the next 24 hours, and it will link you to a short evaluation survey for this webinar. Once you've completed that survey, you'll be able to print a certificate of completion. So in future, please see Tobacco Free RNAO website for our upcoming events and webinars. Thanks so much again to Dr. Smith for the great presentation, and thank you all for attending.